Welcome to Crash Cart. This is a well-perfused production. Welcome to Crash Cart. On this episode, we're going to be discussing steroids and septic shock. I'm Dr. Noah Blaker.
And I'm Dr. Faz Sada. I'm one of the first-year residents here at the University of Florida at the internal medicine program, and Dr. Noah Blaker is a second-year resident at the same internal medicine program. Today, we are lucky enough to have our guest, Dr. Lyle Miller, to discuss the topic of when to use corticosteroids and septic shock, and what he's seen in the ICU. He went to the University of Tennessee for undergrad and for medical school, attended East Tennessee State University. Dr. Lyle Miller, thank you for joining us.
Happy to be here.
Excellent. So first and foremost, my number one question, what is your favorite place to eat here in Gainesville?
I think it's hands down Mother's. Northwest Mother's, definitely the best of the two, not downtown Mother's.
I've never eaten there. What kind of food do they have?
Anything you can think of, really, but 55-cent wings on Monday nights, you just can't beat it. This is not an advertisement for Mother's, by the way. I just truly love them.
But it is Sunday, and tomorrow's Monday. So
it is, but they are currently closed.
Okay.
Well, it had nothing to do with their quality of service, I swear.
Fair enough. So for today's episode, I wanted to kick things off with some of the pearls I've picked up in two of my rotations here in the medical ICU. One of the first things I've noticed is, personally, I don't always use the words sepsis and septic shock accurately, and it wasn't until roughly my second time around that I realized, one of the most important things is precision of language when we're talking about patients and their conditions. So for sepsis, for example, at the very bare minimum, when using that word, we have to have a source of infection as well as evidence of end organ damage. Now, some guidelines will say that's in the context of SIRS criteria as measured by a QSOFA score, but it can also be end organ damage as evidenced by clinical manifestations of lack of perfusion to end organs, whether that's chest pain, reduced urine output, or even on labs, acute liver failure evidence, or AKI, possibly tropes in the setting of type 2 demand ischemia. So these things, I think, have helped me be a bit more precise when I talk about patients. Another pearl that I got to pick up, especially during nights, and it was a pearl that I picked up from the first MICU rotation, was there are moments when a patient will get very hypotensive. You're looking at the A-line, and I am sweating buckets because those maps are dropping fast. And you don't know if this is an appropriate situation to use fluids or if that might make it worse. So one of the pearls was the attending had mentioned the top two highest sensitivity and highest specificity methods to determine fluid responsiveness in the hypotensive patient is actually passive leg raise on exam in combination with bedside POCUS measurement of the IVCs, in particular the distensibility index. And it's interesting because you have about 200 to 300 cc's bolus in your lower extremities when you're doing this passive leg raise, and that's essentially equivalent to hitting a liter of LR on Epic when you're submitting your orders. Because if you have about 25% of a liter that you give that actually ends up in your intravascular space, that's essentially the same as the passive leg raise, which is dedicated 250 to 300 cc's. So these things have helped me a lot in clinical practice. So Dr. Miller, one of the main questions I've run into is, when do I know when to start corticosteroids in patients that are already on pressors? I don't always see a pattern of when this happens, or maybe I haven't picked it up, but I'd love to see what you've picked up in your experience so far.
Yeah, so according to the Surviving Sepsis Guidelines, it's recommended that you start pulse dose steroids when you either have norepinephrine or epinephrine running at least 0.25 micrograms per kilogram per minute, and that it's been on for at least 4 hours in order to maintain a MAP greater than 65 millimeters of mercury.
So that's really helpful. One of the follow-up questions I have is, when I'm sitting down to place these orders, how do I know when someone says, hey, we need stress dose steroids on this patient now, they meet criteria or clinically we feel that they can benefit? How do I know which corticosteroids to start?
Yeah, so according to a trial called the Approaches trial, they looked at both IV hydrocortisone and IV fludrocortisone. So for IV hydrocortisone alone at 200 milligrams per day, it showed faster resolution of shock. However, it didn't show any mortality benefit. Now, if you combine the two and do IV hydrocortisone 200 milligrams per day along with IV fludrocortisone 0.05 milligrams per day, then you get the benefit of both faster resolution of shock and also mortality benefit.
How much faster was the time to getting off pressors in that trial?
I think it was almost 20 hours difference.
I think it was exactly 20 hours. I think it was the difference between 40 hours on pressors versus 60, almost an entire day that you're saving by using both hydrocortisone and fludrocortisone in combination. People have asked, well, what's the reason for that? If they're both steroids, why do we need two? And that's because of their different mechanisms of action. With hydrocortisone, you're really getting the anti-inflammatory effect and the tamping down of the immune response effect, kind of taking care of the systemic inflammation that exists in a sepsis scenario. The fludrocortisone, in contrast, has mainly a mineralocorticoid effect. So you're really helping to preserve intravascular volume with that one. So going back to Fez's point about passive leg raise tests and fluid responsiveness, let's say you've had a patient that's been on pressors for a day. They're on 0.25 of norepinephrine plus maybe vaso, and despite adequate fluid resuscitation, you IVC scan them and their IVC is still completely flat. The fludrocortisone is really what's helping you maintain your intravascular volume. One of the things that we often see in the ICU is sometimes people say, well, I'm not sure if I want to pull the trigger on stress dose steroids. Let's just do one or the other. Let's just do hydrocortisone and we'll wait on the fludrocortisone. After your review of the Approaches trial, what do you think, Lyle? Should we be waiting to pull the trigger?
No, go for it. Just start them both.
Dr. Solit, were you aware of any data that said that this worsened outcomes by starting stress dose steroids at this point?
So certainly I haven't come across any papers that point to outcomes being worse. There was, I think in 2019, if I'm not mistaken, 2019, it was a trial called the Coitus trial, aptly, interestingly named. But that showed that that was one of three trials. Out of the three trials that looked at fludro and hydrocortisone together, it was the only one out of the three that showed no additional mortality benefit. But as far as I've seen, no harm, certainly.
Yeah, and that kind of points to one of the difficulties that pertains to studying ICU medicine as a whole. Is it's difficult to study and the patients are so ill at baseline, you may not be able to move the needle regardless of what intervention you throw at them. But it is reassuring that we do have the positive trials that indicate that starting steroids at this point do have a benefit in treating these patients.
Agreed. That definitely helps make a decision in a pinch when, especially, you likely won't be causing too much harm or really any harm by going with an option that has both. One of the things I had forgot to mention earlier, and it's relevant now, is also when we say septic shock, what exactly does that mean, especially for someone at the level of a first-year resident coming in, taking care of these patients. So before we say someone is in septic shock, a lot of the definitions, guideline definitions, imply that you are already using vasopressors to maintain MAPS above 65, and you have a lactate greater than 2, and this is despite fluid resuscitation.
I think that's an excellent point. I now have a question for Dr. Miller that is completely unfair, but I'm interested to hear his thoughts. So as we've already articulated and you've taught us, when norepinephrine is at 0.25 or epinephrine for that matter for greater than 4 hours, it's not that you have to start stress dose steroids, but it's that you can and that there may be some benefit. What is your personal practice when dealing with septic shock? Are you typically starting a second pressor before you're willing to consider adding stress dose steroids, or do you go ahead and start those steroids early?
So it's difficult with us being residents. I don't get that call many times, but I will say it's definitely provider preference. Some attendings I feel like are a lot quicker to start stress dose steroids versus others are more likely to just go ahead and start vasopressin.
That's right. And Dr. Solid, do you have any thoughts on why steroids would be beneficial? Shouldn't our adrenal glands be doing the job?
That's an excellent question. The first thought that comes to mind is when a patient is in florid septic shock, I don't imagine that their adrenal glands will be the most reliable in terms of providing the anti-inflammatory and blood pressure support that it otherwise would. At least that's my pathophysiological basis for it. I don't know if you have any other thoughts.
No, that's exactly my thought. When we're dealing with septic shock to the point of instability, really we're beyond what the human body can maintain homeostasis in. The adrenal glands just weren't made to tolerate that kind of onslaught, so it would make sense that the additional support would support overall recoverability in the same way that our own natural responses can't come up with the kind of force that pressors allow us to maintain.
Certainly. I mean, in the absence of adequate perfusion, you can't really bank on your organs to perform the way that they usually would.
So hearing all of this, what is your main takeaway from everything Dr. Miller has taught us?
If I could summarize the main points, the ones that I will be taking on to the MICU probably in the next roughly 1 week, is I now have a basis for when to start stress dose steroids, that even though it is provider dependent, I know that at minimum the option becomes available when we are running now norepi or epi at 0.25 for 4 hours, and our goal is to maintain MAPS above 65. I think the hard part that will be something that I will have to accept is that this is provider dependent. It's not a textbook answer. And so some folks may practice it differently, but it won't necessarily cause harm. And finally, our pearls about how to assess intravascular volume status fast and effectively.
I think that's excellent. And now comes my favorite part of the show, where we ask Dr. Miller, what do you think it takes to be a good resident? What advice do you have for other people entering the field of medicine, people who are already in it from your perspective?
Yeah, so I don't know. I mean, I think over the past year and a half, what I've noticed is that being a good resident doesn't particularly mean that you're the most knowledgeable. It usually means that you're hardworking and you look out for everybody around you and try and take work off of everyone else and take responsibility for your patients. I think that's what really shows to attendings a lot more than knowing some bullet point that you will eventually pick up during your 3 years of training.
Do you think the patients appreciate it too?
I definitely think so. I think that they appreciate us spending, the extra time whenever we can, dropping in, making sure all the orders are in, and especially whenever it comes time for discharge, making sure that everything's lined up and they're aware of what they need to be on and what, office visits they need to make, because, the ball can really get dropped after several days of providing good care, and then it can all go through the holes right at the last minute if you don't have a great discharge plan.
That's certainly true. And really what you're describing is patient education and also empowering the patient to take charge of their health, which I think is super, super powerful.
Yeah, definitely.
Excellent. Well, thank you all for tuning in to our second episode of Crash Cart, and stick around for the next one.